Oligometastatic prostate cancer can be variably defined as the presence of 3 or fewer to 5 or fewer lesions outside the prostate or prostate fossa. We oftentimes divide this further into either synchronous or de novo disease, where the patient is presenting for the first time of their initial diagnosis of already have metastatic disease, or metachronous, otherwise called recurrent disease, where a patient has been treated definitively before and then has a relapse that has some metastases associated with it. Traditionally, we defined oligometastatic disease based off of conventional imaging, which would mean either a bone scan or CT abdomen pelvis, perhaps an MRI as well. However, if we look at the 2 original randomized phase 2 trials that evaluated metastasis-directed therapy versus observation, specifically in prostate cancer, we do see that even at that time, there were 2 distinct approaches. The first one, STOMP, used choline-based imaging, so actually did use PET-based imaging, while the other, the Oriole trial, used conventional imaging, but also obtained a PSMA PET on all patients and found that the patients who had PSMA-defined disease treated did better. So it's now well appreciated that conventional imaging is not particularly sensitive at the low PSAs that we would like to catch these patients at, particularly in the recurrent setting. And therefore, PSMA-defined oligometastatic disease likely represents the lowest burden of metastatic disease. Conversely, men with oligometastatic disease on conventional imaging might actually have polymetastatic disease on PSMA-based imaging. And so if we're thinking about the disease state where we want to ideally intervene with the highest chance of meaningfully altering disease natural history, it would be in the PSMA-defined oligometastatic state. It's a great question. So currently the use of PSMA RLT in oligometastatic disease remains in the realm of clinical trials. There's no published data yet. However, the rationale from this approach can come from a holistic appraisal of the existing data supporting metastasis-directed therapy, or MDT, in general. This is typically delivered via stereotactic body radiotherapy, or SBRT, sometimes called SABR for stereotactic ablative body radiotherapy. In patients receiving MDT alone, durable control is low. That means there is progression after an initial round of treatment in about 80% of patients by 5 years of follow-up. This can either be what we call an oligoprogression, which means it's oligometastatic again, it's progressed in less than 3 to 5 other areas, or polyprogression, which is a more kind of bulky progression in multiple lesions. We do know that adding a short course of hormone therapy might delay progression, but because hormone therapy, by definition, suppresses disease, it's not clear that this is actually meaningfully altering the true natural history. You might just be suppressing things because you're delivering a drug that does that, as opposed to actually eradicating disease. We did see this in the Radiosa randomized trial that was just published in Lancet Oncology. Adding ADT to MDT for 6 months did improve progression-free survival, but the eugonadal progression-free survival, which means progression-free survival with a normal testosterone, meaning after testosterone is recovered from the ADT, was actually not different between patients who got SBRT and ADT and patients who got just SBRT, which tells us that we're not really improving cell kill outside of the areas that SBRT is already targeting. There are other efforts that have been studied to actually enhance this cell kill outside of our target area. That's what's going to influence, oligo and polyprogression. We had the Saturn trial here at UCLA, where we did intense androgen annihilation with 6 months of leuprolide, apalutamide, abiraterone acetate, and prednisone, plus SBRT to all PSMA-defined sites of disease. We did find that the combination was fairly effective. 50% of men were free of disease 6 months after recovering testosterone, and we enrolled only patients with true metastatic M1A, M1B disease on PSMA PET. But, on the other hand, 50% is not as high as we would like it to be, and 20% of these patients had grade 3 toxicity from this medication combination. So we obviously need a better intervention. Another pathway to improving outcomes would be to use another type of radioligand therapy, like radium-223. And soon to be published is the Ravens trial, which investigated precisely that, adding radium-223 to SBRT in patients with oligometastatic prostate cancer. Unfortunately, there was no benefit to adding radium-223. So we're in a situation where we know polyprogression is a problem, oligoprogression is a problem. MDT alone doesn't seem to totally change that natural history. There are some patients that have a durable cure. Adding hormone therapy doesn't seem to change that natural history. Very intense hormone therapy is pretty effective, but has a significant cost and isn't as effective, arguably, as we would like. And adding bone targeting radium therapy didn't help. So this is where PSMA radioligand therapy makes sense. If we think that PSMA radioligand therapy will actually be cytocidal on the microscopic disease that we know exists, then adding that to MDT may significantly actually improve the natural history and reduce out of field progression more so than any of these other interventions that have been studied. So the first, which actually has had an abstract report a couple of years ago at the EANM conference, is the Bullseye trial. So that's a trial of deferred ADT versus 2 to 4 cycles of lutetium PSMA 617 in men with oligometastatic disease defined as less than 5 lesions and with a rapid PSA doubling time. Their primary endpoint was progression within 6 weeks of cycle 2. Some early results, as I mentioned, were presented for like the first 42 patients, and the progression rates were 77% without the radioligand therapy versus 10% with radioligand therapy. So that's fairly promising. 2 other trials I'd like to highlight. The first is our trial here at UCLA that I ran along with Dr. Jeremy Calais. It's called the LUNAR trial. This was a direct assessment of how much radioligand therapy adds to SBRTs. We had patients with oligorecurrent PSMA-defined oligometastatic disease, 1 to 5 lesions. There could be a recurrence in the primary in the prostate or prostate bed as well. These patients were randomized to SBRT to all sites of disease versus 2 cycles of neoadjuvant lutetium-177 PN2002, so that's a point Lantheus compound, followed by SBRT. We enrolled from September 22 to November 2023. The primary endpoint is progression-free survival based on PSMA-based progression or initiation of salvage therapy, and we will have those results later this year. The last trial I'd like to highlight is the PSMA DC trial. This is a registrational phase 3 trial run by Novartis. That's looking at an endpoint of metastasis-free survival based on conventional imaging, which I believe was what the FDA currently would like for a registrational endpoint, enrolling men with oligorrecurrent oligometastatic prostate cancer, men randomized to get either MDT alone with SBRT or MDT followed by 4 cycles of lutetium PSMA 617.